Bjarni, thank you very much for the introduction, ladies and gentlemen. I think we were treated today with some fantastic presentations. It's always nice to sit down and see such quality work that's being done, but also work that's being done with evidence to back it up, I think, which is so important. Today's presentation also clearly demonstrates that as clinicians, we rely so much on our industrial partners, and in this case Straumann, of course, to continuously develop new technologies. Because these new technologies allow us to meet the challenges we face day to day in daily practice. And of course, that eventually translates into new treatment concepts. And unlike Bjarni, who is a farmer from Iceland, who is resistant to change, I quite like new concepts.
Yeah, this is just the way I'm born, you know.
He can't help himself. But of course, the caveat there is that these new concepts and new technologies have to be based on evidence. And I think that's the important thing, and full credit to our industrial partners, and particularly to Straumann, because there's always a commitment to evidence when it comes to introducing new materials. Now, one of the areas I've been asked to speak on today is this new alloy. It's no longer new, but it's certainly now available widely, the titanium zirconium implant manufactured, or alloy manufactured by Straumann. To me, this is one of the major advances in dental implant therapy. This, to me, is a game changer. And I say this because in my own practice, since I've introduced rock solid into my practice in reduced diameter implants, it has changed the way I treatment plan a lot of my patients to avoid some of the pitfalls and the complications with treatment. Of course, the two main areas for reduced diameter implants are narrow restorative spaces, small tooth spaces where you need small restorative platforms. So consequently, we need implants with smaller dimensions. We also have situations from my side, because I only do the surgery when it comes to implants. I rely on my restorative colleagues for the restorations and the prosthodontic side. But for me, the continuing issue of reduced bone volume in patients is something that we contend with and have to deal with on a day-to-day basis. So the logical move is to move from standard diameter implants to reduced diameter implants to help us in these two clinical situations. So what I'd like to do in my presentation today is to briefly outline what titanium zirconium alloy is. I will show you the evidence that's currently available to support this alloy, and I will briefly show you some clinical applications in the time I have been allocated. So I start with these slides. This is a patient of mine. Implant was placed 14 years previously, comes back after a gap of 10 years with a loose implant crown. Of course, it's much more than a loose implant crown. Here is a patient in her mid-60s. I placed these implants in the anterior region of the maxilla, and she's come in once again with a loose crown on one side, and here we also have a fractured implant. Here a patient in her mid-70s who's had a 4-unit FPD on 2 implants placed, in function for 12 years, fractured. So of course, ladies and gentlemen, one of the problems with implants, and if you're around long enough, and you are in one place long enough and you see these complications, implants do fracture. And although, Bjarni, you've done all the systematic reviews to talk about the frequency or the incidence of fractures, fortunately, fractures are not very common. Maybe 0.5%, maybe 1% over 5 to 10 years. But numerically, as more and more implants are being placed around the world, numerically the numbers grow within your practice. So I see this on a recurring basis in my practice, and these are not so easy cases to treat, especially now if the patients are elderly and no longer have the financial resources for a retreatment.
I think also the problem of the systematic reviews are that they only look at 5-year follow-up. And like your cases, you are showing this after 12 years, 14 years, and now we are treating younger patients. It means that this has to last for decades.
I absolutely agree with you. In your opening comments, you mentioned this, the longevity of the restorations. I will talk about that as well when we talk about some clinical concepts. So here is just to look at the materials that are used for dental implants or the manufacture of implants. You have the 4 grades of implants: titanium, commercially pure grade 1 to grade 4. The most implant systems use grade 4 cold work titanium. And then we have the two most common alloys, TAV or titanium aluminium vanadium and titanium aluminium niobium. And of course you can see the ultimate tensile strength of these materials gradually increases. So there is a very strong temptation for implant manufacturers to make use of alloys when it comes to developing implants that have reduced dimensions, because the strength characteristics and the flexural strength is significantly affected by the diameter and the dimensions of the implants concerned. So a small change in the dimension has a big impact on the strength characteristics of the implants. Here we have a fairly old paper from Sam Steinemann in 1998. He looked at various elements to see which ones had an impact upon osteoblast cell growth. And you'll see that, for example, aluminium sits here. It's under the area where we have an inhibition of cell growth. Niobium is here. And this is actually vanadium. So all the common alloys that we use have materials that are potentially have toxic properties to the cells. And of course, up here you have titanium and zirconium, which are the only two metals that were tested in these series of studies that did not inhibit osteoblastic cell growth. So it was on this basis that titanium-zirconium alloy, or rock solid, was developed. And you can see from the tables here that titanium and zirconium occupy the same column, the transitional elements in the periodic table of elements. So they're chemically very similar materials. And what Straumann has done in the development of this material, for me, is really very, very impressive. Because what they have done is they have worked out that if you incorporate a small proportion of zirconium into titanium to alloy it, and the alloying is at roughly 13 to 70% zirconium within the titanium, which represents roughly about 6 to 8 atoms, or every 6 to 8 atom is replaced, then you develop a material that has much stronger tensile strength properties. The other significant thing to realize is that the alloying at these sorts of concentrations produces what's termed a monophase alloy. Now, if you alloy 2 or 3 different metals together, you have different phases. And each phase is susceptible to chemical attack, a difference in corrosion resistance, physical properties, they're all slightly different. But here we have a purpose-designed material for dental implants. It's the only material developed for implants designed this way that is specifically been made, and it is a monophase alloy, meaning it exists in one phase, and it behaves as a pure metal. That's basically what it means. It behaves like it is a pure metal. And I think this is a really remarkable development. Now, when you look at the tensile strength properties, you'll see that compared to titanium cold work, so this is already grade 4 titanium that has been increased in strength because of the cold working process. Titanium zirconium alloy is another 25% stronger for the same dimensions of the material. So that incorporation of a small amount of zirconium has a profound impact upon the strength of the alloy. Now here I'd like to show you a table. This is data from Straumann. I'll have to explain to you what this means. Here in the white line, this is the fatigue strength criteria. That's for premolar tooth, premolar teeth or canine teeth, which is determined to be the optimum strength for a material to be used in that region of the mouth. And we call that 100%, that line is 100%. And then anything, for example, in the aesthetic zone, the strength characteristics are slightly under that. If it's, for example, a lower central incisor, lateral incisor, or maxillary lateral incisor, it doesn't require the same level of strength, and therefore the strength can come down to about 70%. Correspondingly, implants placed into molar sites have to be much stronger. So the reference line is this line at 100%. Now let's have a look at these implants, which is the tissue level regular neck S, tissue level regular neck SP, and we have the TE implant, then we have the narrow neck crossfit and the bone level narrow crossfit, all of 3 millimeter diameter, and here are the 3 other implants which are competitor implants. So if we look at CP titanium, you can see that this is where these implants lie and their strength characteristics. And you can see very clearly the TE 3.3 in commercially pure titanium is quite a strong implant. If you then superimpose onto this the rock-solid implants in exactly the same geometric dimensions, same implants made with rock-solid rather than commercially pure titanium, you can see that correspondingly these implants are 20 to 30% stronger, which is what you would expect. And many of these implants are actually now close to the level of the molar replacement. And these are reduced diameter implants. Now be careful though, I don't want you all going home thinking that every reduced diameter implant you can use in a molar site now without checking the occlusion, without looking carefully at the dimensions that are to be placed. All right, you still have to make a clinical judgment as to where you place these implants, but they're certainly showing strength characteristics that are becoming more and more optimized.
So to summarize, you feel very comfortable using like the NNC 3.3 or the bone level 3.3 for all premolars?
Yes.
And for some molars? Or
I'm still not brave enough to put it in for a single molar.
Okay. So
but the data suggests you could do that. And I think if you have some clinical situations where the occlusion is favorable and you have issues of the bone dimensions being such and the patient's not able to go through a large grafting surgical procedure, then you could make a rational argument to place a reduced diameter implant into a molar site, provided the patient understands the risks as well.
Mm-hmm.
But it's very impressive to see these sorts of figures.
Like you see
very impressive.
It's very impressive, like you say.
So when I was preparing this presentation and started to look at all these figures again, you know, I really had to sit back and say, yes, indeed, this alloy, titanium zirconium alloy, certainly has a great deal of potential. Now, if we look at the preclinical studies, 2 years ago when I gave this presentation, there were half the number of preclinical studies published. 2 years later, we can see a very strong level of evidence, at least within the preclinical study area. I'll show you one study now. This is the study by Gotlow in a mini pig. This is a mini pig study with rock-solid and titanium zirconium, rock-solid implants and commercially pure titanium implants, experimental implants with bone chambers, both treated with an SL active surface. And you'll see here that from the point of view of the bone-to-implant contact, there was no difference between the two materials. And the mean values for the bone ingrowth, and that is the bone that grows into these chambers, was significantly higher for rock-solid, interestingly, than for commercially pure titanium. The bottom line, of course, is that this study confirms that the SL active surface that was produced on the commercially pure titanium surface can be replicated on the new rock-solid titanium zirconium alloy. I think that's the important message to get through. There is an equivalency, at least, in the surface preparation. Now, in the same study, they looked at pull-out figures, Bjarni. So they did simple pull-out torque figures, and here, very interestingly, the rock-solid implants had higher removal torque values than the commercially pure titanium implants. And maybe that's because of the more bone ingrowth that we saw into those chambers. Now, what about clinical studies? Here I'm even more pleased to see that after 2 years, we have a really strong level of evidence now, not just for overdenture type studies, but we also have single tooth replacements and also short span FPDs. I'll show you one study now, and this is the study by Mark Quirinen and his co-workers. This paper is available early online, 2014. I have already seen the 5-year data for this paper, which is not ready for publication yet, but the preliminary 5-year data, Bjarni, is also just as is impressive. So here we have a randomized control, double-blind, split-mouth, multi-center study. Okay, this is the strongest study design you can have. Titanium zirconium versus CP titanium in the anterior mandible for implant retained overdentures. Now we see here that when you compare the two groups, and this is the 3-year data, the important thing I want to draw to your attention is that there was no difference in plaque and sulcus bleeding indices meaning that any bone changes that we could see, you could rule out that inflammation or plaque was the cause of this, because they were similar between the two groups when comparisons were made. And with the mean data, the survival rates were similar between the two implant materials at 3 years, and the mean marginal bone level was also similar between the two implant materials. One of the issues I have, and Bjarni, I don't know whether you share this with me, but when we look at mean values, it always tends to hide what the underlying trend might be. In this paper, though, very interestingly, and I think the credit to the authors, is they produce a scatter plot of the mean marginal bone. Now, this is much more realistic, because of course the mean is somewhere in between, or the median if you like. We all know when we place implants, though, some cases lose a little bit more bone. Sometimes we cannot explain why that is. Sometimes it could be surgical error. We might overcompress, a little bit of overheating. Maybe the ridge was a little bit narrow. But it's important to understand that when we look at means, there is actually a range, and it's that range that's important to look at. And from my point of view, the implants that tend to lose more bone are actually the interesting ones to study. At any rate, if you look at the curve plot for rock solid, and you look at the plot and the curve for commercially CP titanium, they're identical. So clinically, from a clinical perspective, the bone response is similar between titanium zirconium, rock solid alloy, and commercially pure titanium. So there is an equivalency once again. So we have equivalency in the surface and the surface preparation, and we have an equivalency in the bone response and the tissue response that we see clinically. Plus, we have a material that's up to 30% stronger.
I think this should really be the standard way of presenting the
Absolutely.
marginal bone level with the frequency distribution.
Absolutely. Because unless you're really switched on to statistics and you look at the standard errors and the standard deviations, most of us just look at the mean and we focus on the mean. Of course, that doesn't give us the whole story. So let's look at some clinical applications, and these three I would like to look at very briefly. I've already mentioned reduced restorative space, reduced bone volume, and Bjarni, I think you also mentioned longevity, so I'll have a quick word to say about this as well, and maybe we can have a discussion. Here is a 28-year-old patient with the upper right lateral incisor that needs to be taken out because it has failed endodontically. So this is a small space. I'm not going to place a standard diameter implant because my restorative colleagues need to develop a nice profile and an emergence through the soft tissues. So my job is to give them a restorative platform that allows this to be done. So we take the tooth out and we're placing this implant, an early implant placement protocol, type 2 placement. So the tooth is removed, then after a period of 8 weeks of healing, then we return to place the implant, and here I've placed a narrow CrossFit bone level titanium zirconium rock solid implant into a good axial position. We then use a standard GBR procedures, a combination of autogenous bone chips and bovine bone mineral to close over the defect, but also to overbuild the site for contour augmentation, a resorbable collagen membrane, and full submergence if possible, or if not, at least a partial submergence of the implant and the biomaterials. And more often than not, of course, these cases go through to integration without any major issues, and we have a 1-year restorative result here. As you can see, and radiographically, of course, the bone levels look very, very nice up here. And then I give you the 3-year post-restoration result on the upper right lateral incisor and a corresponding cone beam CT demonstrating the augmentation on the facial aspect of the implant. Here I also want to draw your attention, Bjarni, to the fact that with bone level implant designs, we can reconstruct the bone coronal to the implant abutment interface in a predictable way. Mm-hmm. And that coronal rebuilding allows us to have hard tissue supporting the soft tissue for long-term aesthetics.
I know, Stephen, that you are not doing the restoration, but do you know what kind of abutment was used in this case?
I'm sorry. It's not a ceramic abutment, though.
I think that is maybe also a topic if you are using those diameter-reduced implants, and whether you go for metal abutments or zirconia abutments, because there might be a different strength.
These are definitely metal abutments, but I can't tell you which one it is in the portfolio of the Straumann range, I'm sorry.
That might be a topic for the next Straumann Symposium, the strength of the abutments for those diameter-reduced implants. Then they will invite Chris, I suppose.
Yes, and you want to be invited, right? So here are some other examples. As I said, very small lateral incisor spaces. We can use these reduced diameter implants. And, you know, multiple tooth replacements. We know the problems with adjacent premolar teeth, maxillary premolars, often very difficult to get enough space. So a combination of a standard and a reduced diameter implant. And because this is an implant in rock solid is strong, I'm very happy to have these restored as individual units as well. Right, so it solves a lot of clinical issues we have with reduced space, not just for single teeth replacement, but also for multiple teeth. So now if we look at the reduced bone volume, from a clinician's point of view, we have to make a determination whether we can place the implant and then do the bone graft simultaneously, or whether it's preferred to do the bone graft first, build up the bone volume, and then place the implant in what is called a staged approach. Of course, this can be the topic of an entire symposium, so we won't go through that. But what I will say, though, is that the main criteria for me, whether I do a simultaneous augmentation procedure, is that when the implant is placed, that I am able to do so with the knowledge that there are existing bone walls around the implant. Okay, so if you have, in this case, there are two bone walls, you have a missing bone wall in the middle, we are able to reconstruct this with particulate grafts very predictably, because it stabilizes this area here. You can stabilize the bone graft. You place autogenous bone plus whatever synthetic material you would like. Plus the fact that those bone walls also provide progenitor cells for new bone to form, a new osteoblast to migrate into the site. So that's the main clinical criteria. And we know from a fairly old study now, this is from Nicholas Zitzman in 1999, that if you go from immediate implant placement, which is type 1, to early implant placement at 8 to 12 weeks, to late implant placement, which is 4 to 6 months down the track, and if you look at the corresponding proportion of the sites with bone walls, you'll see that for sites with no bone walls, that you find the type 4 late implant placement, the defects predominate with no bone walls, whereas very few in the immediate to early have, or relatively few, have no bone walls. And correspondingly, for 2 and for 3 wall defects, and these of course I said are favorable, 2 and 3 wall defects are favorable for simultaneous augmentation procedures. And you see here that early implant placement, there is a higher proportion of 2 and 3 wall defects around the implants. And if you then measure the success of the regenerative procedure based on the timing of implant placement, you can see that the success rate diminishes significantly as the timing of implant placement increases, or the time to implant placement increases, because what we deal with here is what is termed a chronic defect with the implant sitting outside of the bony envelope. And here it becomes very tricky, if not unpredictable, to try to regenerate bone on an implant surface like this on a regular basis. Much more predictable if it is within the bony envelope. So here we have a case of a 60-year-old patient who has a vertical fracture of an upper canine. The tooth is taken out. You asked the question earlier, Bjarni, was this a ridge preservation? No, it's not. It's just a collagen sponge that's placed in the socket. I don't know why we do this, because it probably has no beneficial impact whatsoever. But there is some anecdotal evidence to say it might help stabilize the clot. That's debatable.
If it saves you some sleep, then it's worth it.
Saves the patient. Patient looks at it and it's not a big hole, you see. So there's the extraction is done. And here again, we use an early implant placement protocol, 8 weeks later. And what I always like to see is that the soft tissue will often repair itself. You notice how there was a lot of recession on the tooth. Take the tooth out, give it time, and the thin tissue biotype reverts to a thicker biotype. And often the apparent position of the gingival margin corrects itself in a coronal direction. So it gives you a lot to work with. Now we have the preparation of the site up to the second twist drill stage in the Straumann range, which is a 2.8 millimeter twist drill. If I take a standard diameter implant and place this into the site, I now have a no-wall defect because the implant now sits external to the bone walls. So in this patient, in a post-extraction site with an anatomically narrow alveolar process generally, a standard diameter implant would actually start to reduce the chances of getting a good regenerative result and risk the long-term outcome. So here instead, a reduced diameter, rock solid, narrow crossfit implant is placed, and you can see we maintain the bone walls. A narrow dehiscence allows autogenous chips to be placed, then subsequently grafted with synthetic material. In this case, is a xenograft. And then a double membrane technique is used, standard GBR procedures for contour augmentation and submergence of the implant. And finally, after a period of healing, generally I leave these for 10 to 12 weeks. Then with a little punch opening, we change the healing cap to a longer healing cap. The patient then goes on to get the restorative work done, and we have a 4-year outcome in an older patient that did not require then a staged augmentation procedure, or didn't require an implant that was placed which risked exposure of the implant and lack of bone formation because the implant was sitting external to the bone walls. So as I said, this is a game changer for me now, because there are many cases which would have been complicated, or it would increase the complication and the risk of treatment, have now been simplified because we've been able to go down 1 diameter in relation to the twist drills. So Bjarni, here's another case of a healed site. This patient couldn't afford fixed reconstructions, so this is going to be a hybrid of fixed and removable. You can see here the preparation adjacent to one of the canines up to the 2.8 millimeter twist drill stage. We all know if we take the next twist drill and enlarge it and then use the bone level profile drill, completely blow out the bone walls on both the buccal and lingual. But here we have an opportunity to place a reduced diameter implant and preserve the bone walls, which are so important to maintain the viability of the bone around the implants. So here we have a narrow neck crossfit rock solid implant placed on one side, and similarly a narrow neck crossfit rock solid implant placed on the other side. The implants have integrated. On one side, she's had a crown made on the implant to give her fixed teeth from canine to canine, so that if she chooses not to wear the prosthesis when she answers the door, at least she's got 6 front teeth. And then we use the other implant here to help stabilize the partial denture, and we have a very satisfied patient. I think sometimes we don't use enough of these combinations of fixed and removable in these partially edentulous cases. Here's another good example. Diameter reduced rock solid implant placed on one side to aid in retention and resistance to that partial denture. And of course, 4 implants in the maxilla for a locator retained overdenture is a standard treatment today. And more often than not, these cases have reduced bone volume, despite the ridges looking nice and thick. We all know when you lay open the flap, the bone is usually very thin. But this patient was able to have this without significant grafting, in fact, any grafting done. So to finish off now, Bjarni, I'll quickly talk about young individuals. Here's a young patient who's post-orthodontic. She's had orthognathic surgery as well to correct a skeletal discrepancy. You can see the series of clinical photos, radiograph and cone beam CTs. There is sufficient bone here to place a reduced diameter implant, and the plan is then to augment the contour on the facial side to support the soft tissues for aesthetics. So we go ahead, prepare the osteotomy up to the 2nd twist drill, prepare it with the narrow crossfit profile, place the implant. We retain a good bone wall, but once again, this is correcting the contour now for aesthetic reasons. And once again, you will see that the graft is carried over onto the coronal part above the implant healing abutment interface. We want to extend or regenerate the bone coronal to that interface. And now, same series of slides again. It's a standard technique that we use, double membrane, partial submergence or primary closure of the biomaterials. Eventually, the implant is exposed with a punch opening. A larger and longer healing abutment can be attached at that point. And then we go on to the final restoration. In this case, it's just a 2-year restoration. So why do I show this case? This is a case of a 19-year-old patient. So what I want to do is just very quickly pause and talk about this longevity issue. These are data from Australia, and you can get this data from your own country, I'm sure. And if you look at the cohort of young Australians born in 2005, 2006, so this makes them I'm trying to calculate this, 8 to 9-year-olds today, yeah? So at birth, boys have expected expected life expectancy of just under 79 years, and girls will be a little bit like 83.5 years, about a 4-year differential between the two. Now, the interesting thing is, as we grow older, our life expectancy actually increases. So your life expectancy at birth with the trends actually increases at the other end. So by the time they reach 15 years of age in 2020, 2021, their life expectancy will increase by that amount. And by the time these young people reach the age of 65, which is in 2070, Bjarne, can you imagine that? We're talking about 2070. It's just incomprehensible that we're actually going to be in the second part of this century for these young individuals when they reach that age. Well, you can see that's their life expectancy based on the advances in medicine, healthcare, health awareness, etc., etc. So roughly every 20 years that you live, you can add 1 year on your expected survival rate, or life expectancy at the end. That's the good news. And the other good news for the guys is that the difference between men and women diminishes. We're starting to catch up. We're starting to catch up. So, what has this all to do with what we're doing? Well, Bjarne, you touched on this earlier, longevity. So if I show you a case now of a 23-year-old that we're placing implants for this patient, developmentally missing teeth, go the standard placement. Now, if this young lady has a life expectancy of 85 years, how can we reasonably expect the prosthesis and the implants that we place to last 65 years? Okay. Now, maybe this is an extreme example. Bjarne, how old are you? You're a young man? You're 38?
I was thinking about in 2070, I will be 106 years old. I was just thinking of what I would be doing then.
Out in the paddock with the sheep and the...
Yeah, I would be collecting sheep in the highlands in Iceland.
Well, the point I'm making is we talk about young individuals, but what about not so young individuals? I hate to tell you, but I'm over the 50 mark.
Are you?
Oh, yes.
Oh.
Now, my life expectancy is around 85. If I'm good, I might kick on to 90. So if I'm replacing a central incisor or a lateral incisor or a molar, I want that to go for 40 years. So it's not just for the young, but it's also for us in the age group that we're in. And we can't stop complications from happening. Complications do happen. Implants do break. Technical biological complications happen. But as clinicians, we have a moral obligation, a moral and ethical obligation, that when you place a biomaterial or when you place a therapeutic device into someone, then you must satisfy yourself that you're placing the material that's best researched, that's got the best surface characteristics, that's got the best strength characteristics that you have today. Of course, 10 years, 20 years, it will change again. But on the day, you have a moral obligation to do that. And that is why in my practice, all reduced diameter implants are titanium, zirconium, rock solid. It's the best material available on the market today. And I use the SL Active implant surface because, once again, it's the best surface available today. So to finish off, titanium zirconium, I've shown you already, has significantly greater strength than commercially pure titanium implants of the same dimensions. They are above the industry standard for dynamic fatigue strength. Very pleasing to see. And finally, and again for treatment solutions, Bjarne, these are suitable to cover all clinical indications. But bear in mind, of course, that you need to use your clinical expertise and judgment when recommending reduced diameter implants for all indications. And I thank you for your attention.
Thank you.